Go live.
Yes.
Good evening, doctors. On behalf of
Good
Hetero
evening.
Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on Carbetocin in action. At Hetero Doctors, we market products in different therapy areas like in gynecology, orthopedics, dermatology, etc. We have very strong R&D support and we have developed many unique formulations keeping patient benefit in mind. We have developed several film formulations. Recently, we have introduced Carbetocin. Carbetocin, as we all know, is used for prophylactic management of PPH. PPH is a condition which can lead to disaster, which has the potential to lead to disaster. While there are several papers and guidelines which suggest the use of carbetocin, we have eminent speakers with us to give their insights into their experience with carbetocin. Today we have Dr. Abhirup Bandopadhyay. Welcome, sir, for this webinar.
Welcome, everybody. Welcome, Dr. Prashant Khandeparkar.
Dr. Abhirup Bandopadhyay is MBBS MS Obstetric Gynec at MRCOG London. Sir is consultant gynecologist and laparoscopic surgeon and infertility specialist. Over to you, Dr. Abhirup, for your views on carbetocin in action. Over to you, sir.
Welcome, everybody. Welcome welcome, everybody, and all those people who are joining us. And it is a beautiful molecule. It had got reputation of preventing maternal death in a short span of time. And that is the cause 25 nations have allowed the use of carbetocin in prevention of postpartum hemorrhage. And to my surprise, India has been late in joining the team. There have been certain issues of carbetocin, including the price of carbetocin compared to syntocinon. As we know, most of the mothers who got cesarean section or delivered vaginally is to the government child. Government sector also has a lethargy, I should delayed response to accepting the new molecule. But the good part is that finally it has taken up and we are gradually getting the data of use of carbetocin among Indian population. I have experience of carbetocin use almost 7 years. And as we see, carbetocin molecule itself has been copied from oxytocin, which is a nonapeptide, but it has a very small T-half of 3.5 minutes, less than 4 minutes in blood stem. So it destroyed very fast. But carbetocin, on the other hand, has a longer T-half because of modification of some amino acid residues, and it can withstand 85 to 100 minutes when being getting half degree, that's T-half. So it's a longer acting. The advantage of this is that the golden period of controlling postpartum hemorrhage is always been ignored, and sometimes syntocinon is not available even for a short span. But once you administer carbetocin, it will take care for almost 2 hours. That's good part, and only single dose will suffice. In my experience, I didn't have to use multiple dose of syntocinon, carbetocin, or I had to supplant any other urotonics during this procedure while we use carbetocin. Now, this is the good part of carbetocin, that you can use it intramuscularly and you can use intravenously. Because when you do cesarean section, you need very ultra fast response because you must see the uterus to getting contracted so that you can close the uterus, and you need not have to bother about any additional procedures to increase uterine contractility or take care of the tonicity. In vaginal delivery, we can wait and observe. We can give Jollywell, can give intramuscularly because intramuscular injection can be given by the sisters, midwives, while intravenous injection has lots of side effects like dizziness, headache, even hypertension. And because it contracts smooth muscles, it can cause sudden shooting of blood pressure. So, uh, when it is not being used by anesthetist or a doctor by himself, or you don't have the remedies and the infrastructure available to control hypertension and other side effects. So it is better to use intramuscular use. But in cell section, we'll go for the intravenous use so that we can get fast response. Carbetocin especially works where ppH is more, just like multigravida, having multifetal gestation, that's twin, triplet. And what experience, though it is not been recommended in eclampsia and hypertension, when it's used under by judicious use of antihypertensive magnesium sulfate along with carbetocin, we get a very good response. I have a small case report regarding that I have to show you that initially we had a case of Momita Shah. She was 37-year-old, an IVF patient of 36 gestational age. She was admitted with severe hypertension and there was some APAs and antepartum hemorrhage and was put for C-section. Finally, we used traditional method of syntocinon, all these things, and misoprostol, but there was EPH, and as much as 30 units of syntocinon were used. Some of the syntocinon was used in the same section, was given by anesthetist, and thereafter in the ward, and then again SHO was called on. So finally, we calculated 30 units of syntocinon dose was given, quite high. There have been blood transfusion and patient's condition deteriorated. Maxaf was given and she had eclampsia and finally a multi-organ failure ensued. And what happened that she died on the fourth day. We get a bitter experience from that when another lady of 40-year-old Shabina admitted with IVF patients, she was also IVF pregnancy. She had APH and PIH of 35 weeks. We had a dilemma what to use carbetocin or not. Eventually, we used carbetocin and everything post-operatively was smooth. We'll discuss how scientifically this can happen, how syntocinon can differ with oxytocin, and how the final outcome can be favorable. So it's a long way to go before we establish uh, carbetocin as a very safe drug and a safe hands and expertise hand. At the same time, we should try to understand why there was some restriction of use of carbetocin in hypertension, eclampsia, etc. So we have ample scope of studying these things, and we discuss after the other panelists if they're available. So it was another case studies were given. So what is the difference? In one, what is carbetocin? That makes a heaven and hell difference. There's no PPH, there's no fall of oxygen tension, oxygen delivery, everything okay, and the patient's pain response was good, and everything suddenly tilted towards recovery. While in the other case, syntocinon, though it's the age-old drug, it has a propensity to cross the blood-brain barrier. Syntocinon, especially in eclampsia, is very dicey molecule. It helps sometimes. It doesn't help sometimes because blood-brain barrier in eclampsia, by due to inflammation, gets porous. Neurovascular junctions in eclampsia, the gap junctions get damaged due to oxidative stress, interleukins, and transporter molecules. And they allow syntocinon to enter in the brain. And it can cause precipitate eclampsia. It can cause sudden brain destruction, encephalopathy, and actually it can precipitate eclampsia. Forget about this water toxicity, that SIADH, due to high accumulation of syntocinon, which also happens to be a cerebrotoxic, the hypotonic solution that we use in as a intravenous fluid at 5% dextrose, and dextrose is eaten up by the cells. That is also remains and makes the whole blood hypotonic, oncotic pressure drops, and this water also can cause damage of the cerebral cells and can cause precipitate eclampsia And not only blood-brain barrier, in eclampsia, other barriers like hepatic barrier, retinal barrier, the kidney barriers, all these basement mechanisms, which is very nicely controlled, otherwise normal pregnancy is damaged. So some way we have to think, though evidences are yet to come, that this molecule we use to synthesize syntocinon, that is oxytocin, OT, that we use for prevention of PPH and to reduce the blood loss after delivery, may actually complicate the scenario. So we have advantage of Carbetocin is that they actually unable to cross this barrier and has reduced this kind of inappropriate action like oxytocin. That's all I want to suggest. If you have any query, anything, you can really ask me about these things. Dr. Prashant.
Yes, sir. I do have some queries. Again, I'll share the screen.
Yes, please go on.
Yeah. You have mentioned your experience of using Carbetocin, but what I want to ask, sir, Carbetocin, although it acts faster than oxytocin, is it that the frequency of contractions are more or the duration is more? What is it like? Or both?
Frequency of contraction we didn't measure in postpartum patients. We
Okay,
basically get it in the patient in labor, and
okay,
cavities is not recommended in labor in
correct. Only for
section,
prevention.
only for prevention, that is after the delivery of the baby.
Okay,
So it's the duration and
huh,
the force of contraction that matters for us.
okay. The force is much more as compared to oxytocin,
Yeah,
which will
yeah,
make the difference.
yeah.
What can we say as some patient profile where we can expect or anticipate PPH?
Yes, PPH can occur anytime, though
Okay,
it occurs more in twin pregnancy, uh, polyhydramnios,
okay,
when there has been low-lying placenta,
okay,
there's a antepartum hemorrhage already has been there,
okay,
and also there is some, we expect that some retention bits of placenta,
okay.
placenta creta, perfita, all these things. And in our country, we should consider every mother as a
Oh,
candidate for PPH.
okay,
We should allow anybody to go into that stage and lose
correct,
the mother.
correct. And sir, any diabetes has got any relation with PPH?
Diabetes per se doesn't cause
Ah,
PPH.
bus doesn't come. Because these days
Per
there are
se,
many young diabetics, and if they go for
yes.
pregnancy, is there any relations? What I was wondering. Hypertension or
Actually,
diabetes?
hypertension has some relation to PPH. Only diabetes, gestational diabetes, this per se
Ah,
doesn't have
yeah, yeah.
any direct relationship, but
Okay.
as a complication, infection may be there,
Yes, yes.
fetus may be large, placenta is also large in
Absolutely.
pregnancy because of IGF, insulin growth factors, a very big placenta we get in diabetic. So we get a larger area bleeding. So that can happen. That can happen. So directly it's not caused, but we should be cautious in these cases.
Okay.
Including.
Is there any place where you would prefer carbetocin over oxytocin? Oxytocin is still used, as you rightly said, where you straight away prefer carbetocin over oxytocin for prevention of PPH. Any patient profile specific, any cases?
Yes, oxytocin is a free in government sector.
Yeah, yeah,
It
yeah.
is being used for a long time,
Correct.
and it
It's
is
a
a
textbook brand, sir.
textbook brand, gold
Textbook brand.
standard still
Yeah.
now. But as we go for the maternal death reviews,
Oh,
in our tertiary hospital, we have 12 to 15 deaths per month
okay.
coming for a radius of 100 kilometers. Almost more than 150 mothers die every year.
Oh my
And I
God.
am doing this for last 15 years. So maybe 1,000 mothers we had audits.
My
Why the mother died? And as we see, everything did everything that could have been done in a state government sector. Doctor did everything. The ambulance driver had a rush driving. Everything did the max, anesthesia, get the drug. Still, the mother died.
Oh,
And the story ends like that. All on a sudden, renal failure develops, or hypotension develops like that, and we lose the mother beyond of any
correct,
treatment, and
correct,
it's
correct,
landed
correct,
up as a
correct.
very sad story. So, as we go retrospective into these things, why this happens, eclampsia, the mode of uh, pathology in eclampsia has got a recent changes. It
Oh,
is in terms of barriers, blood-brain barrier, as I said.
uh-huh.
So that becomes leaky. It allows
Okay.
water. It becomes all water molecules, drugs, proteins,
Uh-huh.
inhibitors, everything, and also exosomes. Exosomes are small part of the cells that carry certain things, and it travels through the blood-brain barrier. It can break the blood-brain barrier.
Acha.
So that is released in eclampsia.
Hmm.
So blood-brain barrier is damaged. So we are very afraid of water toxicity. We are very afraid of giving uh, 5%
Oxytocin.
dextrose,
Yes, yes.
oxytocin, even drugs also, even
Hmm.
non-steroidal anti-inflammatory drugs, NSAIDs,
Correct, correct.
diclofenac,
Which
even
can
it
cause
can cause,
water
yes,
retention.
even ranitidine and
Hmm.
proton pump inhibitors, even
Yes,
antibiotics,
correct.
everything poses a challenge on hepatic barrier, blood-brain barrier, because that may not meant for them.
Correct.
Okay, normally that is not harmful, but in scenario of where the metabolism and blood-brain barriers and other barriers are lost
Correct.
or
Correct.
damaged, the long-standing inflammations and other uh, PAMs and DAMs, they say,
Hmm.
damage associated molecular proteins. We did long research on that, DAMs and PAMs, pathology associated damage molecules, HMGB1 and other molecules also we studied for a long time, almost 15 years. So we got things that this is basically causing a like a detonator. It is actually detonating the whole explosion.
Oh,
So while the this exosomes comes, you give the drugs, you give fluids, temperature variations, all of a sudden happens. And as eclampsia has happened already, that means it has already been triggered. Is
hmm.
already 50% of damage has been done.
Okay.
So I would prefer if you, I have this all not in the text, we could recommend it. We
This
know a
out of
long way to go.
experience, yes.
It is from experience, I'm telling. I have a long way to go before putting it as a guideline. We have to long studies
You are
and
correct,
this
correct.
all toxicity, a long way to go. I have seen the carbetocin also restricts use of intravenous fluids also.
Oh,
Yes, if there are less BPH, with there are less fluids, okay, we can stop the intravenous fluid earlier, and
correct,
also we can stop use of 5% dextrose. We
correct,
can
correct,
use
correct.
restrict the use of other things. So the whole intervention should be minimized. So I will
Right, right.
prefer carbetocin in these cases
And in
where there is
patients,
hypertension,
yes.
where there
Voice is breaking, sir.
dementia, where there is other problems like hypertension,
Hmm.
and all these things are there.
In patient with alternate uterus, I think carbetocin would be preferred over oxytocin, like twin
Yes,
pregnancies, fibroids, and other
yes, that is the cause of
cause.
PPH.
PPH,
In
correct,
every of these cases, it will uh, give a better contraction that
correct, correct.
naturally occurs in syntocinon. And the
Absolutely,
dose of syntocinon, as we have some bleeding, we rush for the higher dose. That's a
hmm.
very dangerous thing. We give
Absolutely.
inter we give intravenous 10 units, 20 units, and the SHO over the phone asks the midwife, "Oh, give syntocinon 20." Okay, it's not a give prostadine or you give methargine like that,
Hmm.
and that thing is minimized by using Carbetocin. You
Carbetocin,
use it and forget the things.
very easy to use.
Yes, if it is monitored nicely.
Yes, obviously. This is can we use carbetocin in cases of retained placenta?
Actually, written placenta, you have to explore. Okay, where the tentative pool doesn't work, it is very dangerous to pull it too much because it can invert the uterus. It
Yes,
can be
yes,
placenta acreta, lots of blood can come out,
correct.
and you need relaxation of lower segment. You need
And
contraction of the upper segment, and you need relaxation of the lower
lower
segment.
segment, correct.
So, if you ask me,
Oh,
I will refrain from using that,
oh,
because if it is retained, that means something odd has happened.
hmm.
So, we have to explore, give some tentative pull, go
Correct.
for the OT, and
Simile.
see
That is
that
the
what is
safest.
happening. Yeah, and especially post-CS cases. And
Yes.
nowadays, IVF pregnancies, we have been in the earlier days, it's very easy to get the placenta out.
Correct.
Okay, nowadays, we get some bits retained, and you
Uh-huh.
have to explore, you have to go to the OT.
Correct.
And
Correct. Correct.
yes, after the delivery of the placenta, you
Hmm.
can use carbetocin.
Yes.
If it is not already syntocin be
Yes.
used or
And
else.
only if the os is open, of course.
Yeah, only without open
Oh,
you can't deliver.
you
You
can't.
have to keep it also open.
Right.
Definitely.
Can we use carbetocin in Rh negative mothers?
Per se, there is no contraindication. As
No.
such, no contraindication
Yeah.
because the fetal hemorrhage, if it
Correct.
occurs, then you have to check it other ways by counting the fetal cells in maternal circulation, etc. And you can give it. You can give it.
And
And I think you should because if
hmm.
mother is negative, so getting negative blood is not easy thing.
Right. Right. Very correct.
Especially O negative, AB
Yeah. Yeah.
negative.
Yeah. 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 They are a
We
rare
get this
rare
blood.
commodity. Yeah.
Yeah, yeah. And getting 2 to 3 minutes of blood will be difficult for
Correct.
everybody, every blood bank. And another thing is that we can have H blood group, Bombay positive blood groups also.
Hmm. Hmm.
So for this sense, we should use it. We should allow the mother to go for bleeding and PPH.
Correct. Prevent that.
We
Can
should
a
prevent.
doctor use carbetocin for prevention of PPH if oxytocin is used for labor induction? Of course, oxytocin will always be used for induction and for second stage. So, can a doctor use carbetocin after that for prevention of PPH?
What happens?
Hmm.
Uh, this oxytocin and carbidase competes for the same receptor, that
Receptors,
is
correct.
OT receptors.
Correct, correct.
And as it binds,
Huh.
it causes activation of the post receptor
Receptors.
translations,
Yes,
etc.
yes, yes.
And it doesn't allow oxytocin to bind. So
Carbetocin to that.
that means if you give carbetocin, the uterus becomes refractory to oxytocin.
Oh,
So, so use of oxytocin to
huh,
supplement use of carbetocin, it
huh.
doesn't match too
Yes.
much. If you given the carbetocin, that means that the action of carbetocin will be over for at least 2 hours. So
Okay.
in that period, oxygen will not work. Okay,
Because of the
just you are
common
giving,
receptors.
because have always been accommodated. So
Correct,
all the receptors partially been
correct,
agonized.
correct,
Okay,
correct, correct.
also antagonized to some sense,
Yes, they'll
partial
be blocked.
agonized,
They'll be blocked. Yeah.
blocked.
Yes, correct.
So in that case, you can use carbetocin, but reverse is not true that
Correct.
after carbetocin, use of oxytocin
Oxytocin use.
has no use.
In which cases you would prefer IV route or IM routes? You said
As I
earlier,
said, yes,
cesarean
and
section, you said one place.
yeah, yeah,
Yes. Any other
yeah,
place
yeah.
you would prefer IV route apart from cesarean?
Actually, it depends who is administering,
Ah,
the person who is administering, and what is the case. So
okay.
indefinite route gives us a quick access to
Ah,
our bloodstream,
ah,
and obviously it will higher uh, rate of action in a
okay.
small time period.
Yes.
But if you see about the side effects,
Ah,
it will act on the vasopressin receptors like
yes.
oxytocin.
Yes.
It can cause contractility of the smooth muscle, it can shoot
Mm,
blood pressure, it
mhm.
can cause tachycardia,
Retention of water.
nausea,
Okay.
vomiting it can cause. And I think if it is not in cesarean section, anesthesia is not present and gynecologist is not there, it is his discretion. You have
Okay.
to manage all these things. Time also. You
Yes,
have to
yes.
devote time to care of these things.
Yes,
If
yes.
you have lots of patients are there, you give IV to at random everybody, and you feel the
No.
side
Yeah.
effects. In out of the 100 in a week, you feel
Ah,
one casualty.
okay.
So yes, if you're in a large scale hospital, I have recommended IV. IV works very good. The people
Ah,
started using IV. Then it does not happen to a single patient, but when it comes thousand or 10,000,
ah.
they will definitely have the side effect taking
Yes,
place.
yes,
It's
yes,
told.
yes, yes.
So
Correct.
better not to give IV. But in cesarean section,
Yes.
you can give IV because
And
anesthesia is there. You have time.
And I would have a longer duration of action, I suppose, the more duration effect, I'll say. I am.
So it takes time to absorb.
Yes,
So it will take time to eliminate it. That's
yes,
it's common sense.
yes,
Common sense. So, but as a whole, total effect will
uh,
be the same.
same. If patient is not responding adequate with carbetocin, what would be the additional uterotonics that can be used in those cases?
If you ask me,
Yes,
then
sir.
I would say that it is not the uterine atonicity that is
Ah,
causing PPH.
okay.
So if you ask me that
Ah,
other causes of PPH is there. So there may be some direct bleeding from AV malformation. There may be very infected uterus is there, and
some
some
tears somewhere.
injury tears in somewhere is
Yes.
there. You look for them also. But still, if you see that uterus is not contracting, so you can give methergine, you can give
Because,
PGF2 alpha and all
okay.
this prostaglandin and misoprostols. It will work from the prostaglandin route of works, but I think that really happens.
Yeah, but you have to also consider other possible
Yes,
causes of
also
bleeding.
cervical tear may be there. There may be some
Yes, yes, yes.
arterial
Or maybe a
bleeding
recent
from uterine.
retained placenta.
Maybe.
Yes.
You have to look for do a ultrasound and search for the written bits.
You partly answered is what are the advantages of carbetocin over oxytocin, bisoprostol, carboprost, and methyl ergometer?
So as the drugs came, evolution of uterotoxin has been there. Misoprostol has been the latest before carboprost, and oxytocin and methyl alcohol is argot alkaloids and the age-old drugs.
These are my
So
age drugs.
yeah, it is 50 years old drug.
Yeah.
Okay. And in the list, carboprost has come. It has definitely some advantage. So researchers have evoluted in seeing this not only in human but also in veterinary uh, veterinary use of carboprost is there to minimize blood loss in animal after animal part because in zoos all these things
Oh,
the precious animals are there. You have to take care of them also with human habitat contagiousness, I should say, that they have also developed PPH. Before that, PPH was quite unknown in
oh,
wild,
oh,
wild,
animals.
but in captive animals or in veterinary animals, they do have some this kind of things. And study over them has shown the carbohydrate is still a promising work. And I would say that gradually they will be replaced, if
The shift
not
will be towards, yes.
to some extent at least.
Should carbetocin be kept as a reserve drug or it should be used as a first line, in your opinion?
Any invention in science should be made available for the
Oh,
present.
first
While
line.
X-ray, yes. Firstly, this is my philosophy of
Yes, yes,
thinking.
yes.
Yes, as the X-ray was invented by Röntgen,
Oh,
within 7 days of invention, uh, they used in a complicated orthopedic surgery. Within
oh,
7 days. That is the
correct.
shortest time known in medical history
A new
in
invention at least.
invention and use. So carburation took decades to develop.
Yes,
It took decades, almost 15 years it took. Hard work has been devoted over this drug to prevent, because WHO also backed this project because of maternal death, not only in
correct, correct,
India
correct.
or Asia, but also Africa, Latin America,
Correct, correct. Globally, globally, yes.
vast area where home delivery is also a choice
Right,
because geographically sparse population in high altitude Scandinavia, they prefer for home delivery. So
correct,
for them also, we need a drug that will really stop bleeding
correct.
before coming to the healthcare facilities. Okay. So I would say that make them available, but as 25 countries allowed them, but rest of the more than 100 countries didn't. They have
Hmm.
their own perspectives. I would say
Protocols.
protocols. Okay, many things can happen, but as a scientific mind, I would say that make them available, and pros and cons should be they should aware of the use and not to overuse it, and that is the best win-win situation.
Correct. How would you compare adverse effects or side effects and contraindications of carbetocin over oxytocin and other uterotonics? Of course, when it comes to PPH, the last thing we consider is adverse effect. We consider effects
Yes.
more, but then also overall adverse effect of contraindications.
so, so no drug is devoid of adverse effect.
Absolutely. If
When
it does not have
when
adverse
there
effect,
is
does not have effect.
the drug which doesn't have effect at all
Correct.
does have some side. Even oxygen
Absolutely.
can cause blindness.
Yes.
That doesn't mean that we have stopped using oxygen. Okay. So there are advice because use and judicious use makes everything and the adverse effect apart from the cardiac arrest
Correct.
and blood pressure is manageable
Hmm.
like dizziness,
Correct.
headache, vomiting, nausea, gastric upset, and some numbness. Long list like any drug you have a long list of side, but that's minimal. So far, anaphylactic reaction also has occurred, but
Oh,
that is less, and I think it is acceptable within acceptability. But still, we are still trying to tell whether something can really adverse things happening with them. When you use more amount of more
yes. There are
population will be
more
covered,
data. Yes.
then more data will come coming. Then we'll be able to answer it rightly.
Right. And last question is, how would you conclude efficacy, safety, tolerability of carbetocin vis-a-vis other uretonics?
In one word, we should go for it.
Hmm.
We should go for it. And unless we go for it, we will not understand what is happening.
Correct.
In my experience, I was skeptical initially because of price, because of doing something new and leaving the old and tested one. But as I saw, I read into the dynamics of the oxytocin. I have been a bit skeptical about oxytocin itself. And now we should go for oxytocin. We have already kept a small reserve of carbetocin for our personal use so that when there's not available, we can use it as a rescue drug.
Correct. Correct.
That's
Correct.
the, that's the way I have changed myself, and I think my fellow people will go for it and give it a try, and you have your own experience that can match and we can share later on.
Thanks, sir. Sir, one thing I must tell, whatever irrespective of the government guidelines say, the clinical experience of our clinicians are far more important to our practicing doctors. Because when doctors have used and they share clinical experience, it gives a different confidence to the doctors, our own doctors. So thank you for sharing your clinical experience. It was a wonderful session. It was a pleasure discussing with you. I have also had some more insights, to be very honest, on carbetocin and PPH. Thank you so much. And once again,
Thank you.
thank all the participating doctors for taking their time and from this schedule and commitments for attending this session. Thanks, marketing team Hitro, for conceptualizing and organizing this webinar. And as you all will agree with me, this type of program requires super coordination from field force. Thank you, Hitro Field Force, for super coordination. And last but not the least, thank you, IT team Hitro, for your support and guidance on all IT related matters. Thanks once again. Thank you, sir, and thanks all the team. Signing off. Wish you a pleasant evening. Thank you.
Thank you, sir.
You can log off, sir.
Okay. Thank you, sir.